Hi, I hope you're doing well. Today I'd like to talk with you about Chapter 14 of Clenard & Meyer on mental disorders, and I find this to be a fascinating chapter, full of a lot of information that may contradict some of your own beliefs about mental illness, and things that I think will allow you to more carefully and deeply consider this particular condition, which many people believe falls under the category of deviance. There's a discussion here about many people experiencing minor mental problems like anxiety. So that's something to think about. How many people experience something like anxiety? But then you can think about debilitating anxiety and the idea that there may be a level of this that may be so profound that it impedes someone's normal function in everyday life. And so that's something to consider, what counts as mental disorders and how profound must they be to be something to be considered deviant. Also, though, it says a particular person said 30 years ago I was given a diagnosis of schizophrenia. I was told I would never live independently, hold a job, find a loving partner, get married. I'd spend my days watching TV in a day room with other people debilitated by mental illness. And this is a quote from Ellen Sachs, who became a professor of law at the University of Southern California. So there's the question of what's the role of being labeled, and how does that potentially impact a view of someone who might be perfectly capable of healthy, normal behavior. These are things that we're going to play with in this chapter, and I think it's important to consider. It mentions about 1 in 4 Americans experience a mental disorder in the course of a year. And so that's a good number of people. If 25% of the population experience this in the course of 1 year, a large number of people. About 6% of the population, though, or about 1 in 17 people, suffers from a serious mental disorder. Nearly half of those with any mental disorder also meet the criteria for 2 or more disorders. We will talk about the criteria and its usefulness and the problems in applying it toward understanding and diagnosing mental disorder. There's a good section on stigma, and it says society will likely impose strong sanctions on individuals suffering from mental disorders depending on the specific behaviors that these people exhibit. So there are a few issues related to this. One of them mentioned people with mental disorders are held responsible for their own conditions. So this is a paradox. Somebody who is deemed mentally ill, having a mental disorder, is seen as someone who has some control over themselves, because we're all presumed to have control over ourselves. And so the idea is as well, a person with mental health issues should see a psychologist or a psychiatrist and might need drugs or medication, and at the same time may not be willing to do those things or able to do those things given the fact that they're not in a position of rational thinking. So that's a paradox to think about with this, and the stigma that's attached to people who are not, you could argue, very or at least fully responsible for what may be happening inside of them. Second, the system of care for those with mental disorders has been separated from that of care for those with physical illnesses. So there's a special stigma for people who have a mental disorder, because physical disorders are things that are believed to be treatable. If you break your leg, that's something you can resolve. Mental disorders, though, tend to have the label of something in remission, that there's a belief that they might never fully be cured. And so that's a possible source of stigma. Third, there's a view that people with mental disorders are violent and disruptive or unpredictable. And in fact, that is not the case. That's usually a result of selective media emphasis linking violence with mental disorders. And recently we've had a lot of discussion about how, for example, public shooters or school shooters probably have some type of mental disorder. That's not reflective of the studies that have been done, where it's a very small percentage of people who have mental disorders that lead to violence. Then we can discuss the psychiatric view of mental disorders. Psychiatrists, it says in your text, continue to dispute whether mental disorders result from physical causes or environmental factors. And so there's a question of whether it's biological or environmental, the source, you could say, of mental disorders. There is an organization, an association, the American Psychiatric Association, that has created a book so that it might help with diagnosis, and it's called the Diagnostics and Statistics Manual of Mental Disorder. And it's now in its 5th edition, so it's commonly referred to as the DSM, and now it's the DSM-5 that's used. We can also talk about the psychiatric view of mental disorders, and that would include a discussion of what's called the Diagnostic and Statistical Manual of Mental Disorder. So the American Psychiatric Association has come up with this book, which is intended to serve as a guidebook for people to, again, diagnose mental disorders and the statistics related to those. It's called the DSM, and now it's in its 5th edition. It's not without controversy. In fact, it's a very controversial document, because you can say that psychiatric diagnoses, according to your text, have achieved a poor record of reliability. Different psychiatrists may evaluate the same or similar symptoms and reach different diagnoses. And then there's the mention here that since its initial publication, some terms have been eliminated as disorders. Neuroses is one example. Homosexuality is another. Gay people banded together and said, this is not a psychological disorder. This is how I choose to live my life, and I'm a fully functioning adult, and that's up to me. And so that was removed as a source of what was considered mental disorder. So there's also some other things that have been removed. There was a proposal of a new diagnosis of paraphilic rapism that was introduced in 1985, and feminists strongly critiqued this and said, no, that's not a mental disorder, that's a criminal act. And so it was eventually withdrawn. It's important to also note that the DSM has replaced the expression mental illness with mental disorder. And what might the difference between those be? Rather than providing specific criteria to support precise diagnoses, the DSM-5 identifies broad correlates that identify features frequently associated with the disorders it details. In this manner, the manual leads practitioners to conclude not that a person is schizophrenic, but that he or she displays some typical characteristics of schizophrenia. So that's an important distinction. Also, on the slide here, psychiatry traditionally classifies mental disorders according to 2 types. Those derived from organic causes, or you could say maybe more biologically related, and those derived from functional or non-organic disorders. Those would be related more toward the environment and adaptations that don't work well for an individual, then characterized as forms of mental disorder. A little more on each of those. Organic mental disorders trace their origins to identifiable, as mentioned, organic or physiological problems. So there's some examples mentioned in your text. Senility, old age psychoses. So something that when you get old, you might to perhaps develop psychoses. And paresis, it's a condition caused by syphilis. Untreated syphilis can lead to progressive brain degeneration and also to alcoholic psychoses. So excessive drinking, chronic alcoholism is associated with vitamin and nutritional deficiencies and may sometimes produce severe physical and psychological deterioration. Next, let's consider functional mental disorders. And these would be disorders that function to adjust individuals to their particular difficulties. So, as an example, you could have minor disorders like neuroses and compulsive behavior. So somebody, for example, who does compulsive hand washing, for example. Phobias. People can be afraid of heights. People can be afraid of small spaces. People can be afraid of certain animals. And those are things where the person's trying to adapt to a difficulty that they face. A manic depressive behavior. Bipolar disorder. There's a good section on this where it says that individuals may move from extreme elation to extreme depression, shifting very abruptly and noticeably from one mood to the next. So the manic stage would be frenetic, and the depressed stage might involve things like brooding, extensive brooding. Some other functional mental disorders. Paranoid behavior. Paranoia shows up as an extreme suspicion of people and conditions, with ideas of personal persecution reinforced by an intellectual defense that appears to have some basis in reality. So there's perhaps a kernel of truth to it that then gets extended out to many other things which don't involve anything where the person is being persecuted, but that filter allows them to see the world through that lens. Schizophrenia is a very controversial and difficult to fully define mental disorder, and the term there, dementia praecox. Symptoms include things like hallucinations, delusions, diminished ambition, and social withdrawal. So the question becomes, which of those things, to what extent, and in what combinations, would lead to somebody being labeled schizophrenic? Let's do a question from your textbook. Which of the following is not mentioned as a method for solving the variations in standards for behavior? And if you've read the book, you should know that it discusses the first three, but not D, a criminological definition. Next, let's talk about normative definitions. Redlich advocated another method for making the clinical classification of behavior as normal or abnormal, and looked at three particular elements, very useful to think about, also too in general terms for what counts as deviant behavior, but also for mental disorders. One, we should consider what's the motivation for the behavior. Two, the situation in which the behavior occurs. Three, who's making the judgment, experts or the general public? So, behavior that contradicts one society's norms of ideal mental health may seem like a perfectly normal practice to members of another society. And you can make a case that in complex societies, when people's roles are numerous, varied subcultures lead them to display behavior considered normal in their own group, but classified as clinically abnormal by psychiatrists. Your textbook states residual norms under that category. A sociological definition would specify mental disorder with reference to residual norms and societal reactions to them. Groups establish norms, including crimes, sexual deviations, drunkenness, and those apply to specific behaviors. So that bullet point, the indented one, a violation of norms not covered by other specific behavioral expectations. So the definitions identify mental disorders by observing violations of society's normal behavioral expectations. However, the normative violations of mental disorder often prove difficult to specify ahead of time. Sociologists describe the related norms as residual or left over for this reason. Actions are viewed as normative behavior not only in and of themselves, but also according to expectations for the social context in which they occur. There is variation in diagnosed mental disorders by variables like social class, sex, age, race, ethnicity, marital status. We'll go through them. Generally speaking, social classes, severe psychiatric disorders show a disproportionate concentration in the lower social classes, and it says the lowest social classes. So it mentions in your text, even after additional divisions in one study according to sex, race, age, religion, social class remained the most important variable. There is a strong relationship between schizophrenia and social class. People at the bottom of the class system develop schizophrenia at a rate 5 times higher than people at the top, according to one study called the Chpt studies. There's a couple of other things. Bipolar disorder occurs relatively frequently among young people with few years of education. Then there's a debate. Does membership in the lower class cause mental disorder, or do mentally disordered people slide into the lower class? So that's a fascinating debate. What's cause and what's effect? Under sex, women develop manic depressive disorders at higher rates than men. And there's a lot of information under social class, sex, that I won't be able to get into here. You'll have to look and read. But a couple of points I can make. More men than women experienced any disorder over their lifetimes. Men tend to display antisocial and substance abuse disorder more often than women. But women more frequently develop affective disorders. And also, women may seek help for psychological disorders more willingly than men. You can also talk about variations in diagnoses based on age. And it mentions here the age group from 18 to 29 has the highest concentration of diagnoses for schizophrenia, and that as a person ages, the likelihood of being diagnosed with this decreases. Race and ethnicity. African Americans have higher rates of both lifetime histories and active disorders than whites. In your text, a lifetime rate of schizophrenia for African Americans is twice as high as that for whites. Review question. Those who have never married, divorced, or separated have higher rates of schizophrenia and bipolar disorders compared to married people. True or false? The answer is it is true. And you can think about that in terms of cause and effect. Would it be that people who have schizophrenia and bipolar disorders are less likely to get married? Or might it be that married people have better social supports that might prevent them from becoming mentally disordered? So, as the previous discussion, you can look at marital status and ask those kinds of questions. What's a relationship between being married, divorced, separated? But also you can think in terms of Durkheim's anomie, that people who are single are more likely to engage in some deviant behaviors like suicide. So it makes sense. Social stress is also something to consider, especially when you think about mental disorders. Social stress may exhibit similar links to mental disorders and also seems directly related to behaviors frequently defined as elements of mental disorders. Your text states, social stress contributes substantially to mental distress that individuals experience. And it's fascinating to think about how, if you were in a socially stressed situation, how that might have you engage in behavior you never thought you would. Behavior that you would say really isn't you, it isn't characteristic of you. Few people would deny that stress plays an active role in modern life. There's so many examples in your textbook. Fear of crime, disease, accidents, divorce. Blended families can be a very strong source of stress. They may not blend. Parents might complain that the demands of parenting have increased. Work can be uninteresting, very stressful at times, rushing to meet deadlines. Household chores never seem to do themselves. So, to what extent are we bombarded with stress in our lives? Certain types of stress disorder seem associated with specific proportions of such stressful life events. So you're going to see periods of your life where you may be more significantly stressed than others. For example, immediately following the birth of a child, perhaps after a divorce, or the death of a significant person in your life. Again, social stress contributes substantially to mental distress that individuals experience. So it says a notion that there is a relationship between these two, an undeniable relationship. And that can be for adults, kids, adolescents, even seniors they talk about. So kids may experience high expectations from parents, comparing themselves with other kids, and may also feel frustrated by an inability to control their own activities. They don't have autonomy yet. Adolescents are encouraged toward after-school activities. There's questions about being popular, ideas about your image and the way that you're accepted with others, conflicting demands of friends, schoolwork, and also to fear of the future. Senior citizens sometimes feel disappointed in their golden years. Medical manners are more significant. Medical procedures and following medical advice costs a lot more money when you're older. Friends die off, and many people might experience social isolation. Stress also plays a visible role in neurotic, compulsive behaviors. So, in your text here, it mentions an effort to resist compulsions can sometimes bring only mounting anxiety. So these kinds of things where people are engaged in compulsive acts or repeating certain words, compulsive thinking, and obsessions like tapping, counting, saying set words over and over again, those may relieve anxiety for people. But they may also be seen by other people as signs of a mental disorder. Stress in social situations. Functional mental disorders appear to arise out of continuous series of events that unfold over long periods of time. Now, it says immediate stress situations exert particularly important effects in manic depressive disorders. Observers of note, too, though, that members of lower class peoples experience more unpleasant events than others, and they may have the greatest difficulty in dealing with these problems. So the question of being lower class, does that promote a certain amount of stress that then continues over a long period of time? And the idea, too, here, this could be the result of indicators among social classes, things like income, education, occupational status. So somebody with a lower education level is also perhaps more at risk of certain mental disorders, according to your textbook. There's also some discussion of stress as a precondition for mental disorders. It's important to note that stress does not inevitably produce a mental disorder. A lot of people get stressed out. What's key with stress is how the individual handles that. Do you have appropriate coping strategies for dealing with this? And those might be found through visiting with mental health practitioners, learning strategies like, for example, meditation, talking with people in order to relieve the sense of stress. And there can be maladaptive strategies too, excessive drinking, other kinds of compulsive behaviors. So it's important to think too about coping strategies as important for intervening between life events and what could be mental disorders. Individuals, as I mentioned, need coping capabilities and skills in order to deal with social and environmental demands. And I would strongly recommend looking into these if you haven't. One of the major skills in life is learning how to manage yourself and how you react to certain things. There's no one clear reaction that's supposed to happen with any given life event, and you arguably have some say-so in how you respond to certain events. If you choose to, for example, drink a lot instead of maybe working on mindfulness practices. Those things influence the extent to which you might be more susceptible or less susceptible to mental disorders. Adaptation to stress demands motivation to act and react to situations. So again, there's this kind of conscious, motivated idea of how I'm going to deal with the stresses of everyday life. And it says successful coping depends on both physical and social resources. So another way that, for example, I deal with stress is simply working out. So there are many ways to address these problems. There's a fascinating discussion in your text regarding social roles and mental disorders. There are 4 general theoretical perspectives to examine mental disorders. One way is to look at it through the lens of biological or genetic defects. Another, psychology, so things like personality types. Sociological possibilities for behavioral action. So what are the social reasons that may push someone in a direction of behaving a particular way? And then also to the sociological concept, of social roles. And one thing that your text mentions is this inability to shift roles. It says everyone normally plays many roles, even in the course of a single day. One view regards schizophrenics as individuals who experience problems playing the roles expected of them. Isn't that a fascinating way of thinking about mental illness? So that line, many people who develop mental disorders appear to lose the ability to shift easily or at all from one social role to another. In other words, this person is consistently acting in a way that people would perceive as mentally ill, and it's not changing from situation to situation. Actions and conditions that characterize mental disorder, like withdrawal, depression, compulsions, obsession, and hallucinations, all violate common norms. And so there's work by Chpt, who's been long critical of the mental health institutions in the United States and how mental health is understood and diagnosed. He's advanced a sociological theory of mental disorders that describes such conditions as resulting from playing the role of a mentally disordered person. Society establishes many rather clear expectations, norms, to govern behavior in many social situations. So Chpt says things like, for example, depression and compulsion obsessive behavioral hallucinations are, he calls it, residual rule breaking. And he says those are things that are distinguished from violations of better established sets of norms such as criminal law or social etiquette. Most people, most of the time, fail to recognize their own residual deviance or ignore or rationalize it depending on the circumstances. So let's say you're in the library and you're staring off into space. Most people would rationalize that as, oh, I was just thinking to myself. But it's interesting to think about, well, how might any behavior that you do be possibly seen as an indicator of mental illness, depending on who's doing the viewing and how they strategically, or you could say systematically, consider certain things and not other things. So Chpt's work is very important. It says, when others explicitly identify and label such residual behavior, they begin to organize it into a comprehensive role of a mentally disordered person. So labeling an individual with a mental disorder is then seen as also helping the individual accept and perform the role that he or she is assigned. You can also consider self-reactions and social roles. People experience a self-reaction to their own appearance, status, and conduct. Mentally disordered persons may develop distorted self-conceptions that reflect difficulties in interpersonal relationships and perhaps continued anxiety. The universal capacity of self-conception plays an important role in mental disorder. People may adopt egocentric self-images without logical reason to do so. They may dream of themselves as different from themselves as they truly are, and those self-centered reactions obstruct their capacity to communicate and perhaps engage in interpersonal relationships. Importantly, culture influences the nature of self-reactions. There's some quotes from your text I thought very interesting. Disturbances in language and in meaningful communication, often considered symptoms of schizophrenia, which is one of the most frequently diagnosed mental disorders, indicate the connection of these processes with interpersonal relations. Language becomes a private tool and ceases functioning as a social one. So there's a discussion sometimes people have of schizophrenics as engaging in, they call it word salad. So here's an example from your text. I'm a cut donator, donated by double sacrifice. I get 2 days for every one. That's known as double sacrifice. In other words, standard cut donator. You know, we considered it. It just seems like gibberish. But some cultures may see that person, for example, as someone with divine powers or mystical. Mental disorders may fall along a continuum of behavior as well, and those can be influenced by personal resources, symptoms, and social expectations. So your text mentions in this way a mental disorder may resemble a career path with various potential routes depending upon many contingencies. Acute distress may develop, followed by a reaction that involves some sort of mental disorganization. Then the person may accept psychotic episodes as a real part of the world. At that stage, a person has become quite removed from reality and suffers from severe isolation. Eating disorders, I think, are also a fascinating thing to consider, especially in contemporary times where we have such emphasis on body images through media. You can look at the social dimensions of eating disorders. The term encompasses a variety of behaviors associated with patterns of consuming food. So they talk about two types, mostly in your text, anorexia and bulimia. Anorexia is purposeful starvations, eating small amounts in particular situations. And which of those terms sets up an episodic pattern of binge eating marked by rapid consumption of food in a short time, followed by forced vomiting or laxative abuse. That is the definition of bulimia. So if you think about this, maybe you've known somebody who's bulimic. That person will perhaps eat a lot of food quickly, especially food that they really like, that may be really high in fat or sugar content, fried foods, snack foods, junk foods, and then binging or purging, and that can be either through vomiting or using laxatives. There's also some indicators too, I should mention. If somebody, for example, has been purging over many, many years, doctors will know, dentists will know, because the enamel of their teeth is rotted from the inside, from their continual vomiting. It's sort of a strange thing, but dentists can see indicators of that. How do we explain eating disorders? You can consider psychological conditions associated with eating disorders, and these include things like low self-esteem and feelings of helplessness and feeling out of control of one's body. There's a desperate need to manage control over the body. You could also make a strong case that cultural values increase the likelihood of eating disorders. So Susan Bordeaux discusses things like social standards of female beauty that include things like media images that are expressed in clothing and fashion and in everyday conversations. Can relate to things like cultural stereotypes for how particularly women ought to look. The idea that we communicate weight loss as a goal and a virtue, something that somebody does that should be considered honorable and good. And it says many anorexics and bulimics value conformity, so conforming to those cultural standards. Last stuff we get to talk about here involves the social controls related to mental disorders. In the past, mental hospitals were used extensively. They performed two main functions: treatment that enabled mentally disordered people to return to normal society on the one hand, and then on the other hand, people held in mental hospitals as a form of protection for both themselves and the larger society. As I said, these have fallen into disfavor, and that's been over the past many years, many decades, generally because of the stigma associated with those facilities. The words insane asylums, a lunatic, that those were seen as very derogatory kinds of things, and so the idea of being institutionalized had very strong stigma attached to it. So things changed a lot when President Kennedy wanted to try to deinstitutionalize the mental institutions, remove them from the dominant response to mental health issues. Also, too, there was an increase in the use of psychotropic drugs. Now, it's important to think about psychotropic drugs do not cure mental illness. They address the symptoms of mental illness. So usually these are drugs that are taken over a long period of time, if not maybe even a lifetime. And they became an alternative for people so that they could be treated at home instead of institutionalized. I just mentioned the deinstitutionalization movement. It's quite a mouthful. But deinstitutionalization was the term used for the reduction of hospital populations and the fact that there are fewer mental health hospitals than in the past. It's a movement that began in the 1950s and the 60s, again also related to the use of psychotropic drugs. The movement intended to offer outpatients, including those who have previously experienced hospitalization and those who haven't, a variety of services through local clinics. It should also be mentioned that when President Kennedy wanted to address this, he was interested in the idea that people with mental disorders also have civil rights, and unless they are deemed to be harmful to themselves or others, they have the right to live as they wish to live. So this is also part of a general move in the 60s toward enhanced civil rights for all kinds of minority groups. There have been problems, though, with deinstitutionalization. Alternative care facilities might act in the same custodial and repressive way that large mental hospitals did. So they might be controlling, they might force people to do certain things that they don't want to do. Also, too, there have been a substantial increase in the number of people with mental disorders in, for example, nursing homes, which is not the institution to address that issue. Also, too, there's a disproportionate number of mentally ill people who are homeless. Also, too, people who are in prisons or jails might have a greater percentage of mental illness. Finally, here, community mental health centers have been underfunded, and so there hasn't been a lot of financial support for people to get these kinds of needs met in their communities. The public also, as we've talked about, stigmatizes people with mental disorders as largely potentially dangerous, unpredictable, and in point of fact, that's not fully true. Mental disorders can be managed quite effectively with therapeutic techniques and with medication and with behavioral techniques. So these are myths that nevertheless get kind of carried by a lot of people, and that's very unfortunate because severely mentally ill people will face a lot of forms of discrimination, housing discrimination, employment discrimination, and that in and of itself may cause people to avoid treatment for their disorders, avoiding that stigmatization. If you are diagnosed with the label mental illness, then some people would argue that that would follow you for the rest of your life. And there's a really good article on this by David Rosenhan called On Being Sane in Insane Places, where he and other people who were measured as perfectly sane decided to enter mental health facilities, just saying words that they would say, oh, I've been hearing these words, voices telling me things like hollow and thud. They were more or less, almost to a person, diagnosed as schizophrenic, and then they acted completely normally in those mental facilities. And they were only released as schizophrenic in remission. So this tells you about the stickiness of these labels and the fact that it's hard really to determine mental illness and what counts. Even among psychiatrists, there might be a lot of disagreement. There have been moves, though, toward public education and trying to reduce the stigma of mental disorders. As I mentioned a couple times, most people with mental disorders are not violent. These are problems in living for a lot of people and are increasingly recognized, I think, and hopefully, as things that are treatable, and people live very full lives with these conditions. One of the things, though, that your text ends this section on, the most effective way to reduce the stigma that surrounds mental disorders is to hopefully find the causes of these disorders and then apply appropriate treatment. So, a very controversial subject, and one that you can think a lot about in terms of sociology and deviance.